I'd like to welcome you tonight to our webinar on home alcohol withdrawal and relapse prevention. My name is Nicole Guder and I'm a GP on the Northern Beaches, as well as the AOD Clinical Lead for City North Health Network. I'll be staffing the Q&A and chat boxes tonight. We wish to acknowledge Australia's Aboriginal people as custodians of this land. We pay respect and recognise their unique cultures and customs and honour their elders past, present and future, and extend that respect to Aboriginal people attending tonight. The words detox and withdrawal will be used interchangeably throughout the presentation, as will detox and as will AOD and drug and alcohol. No Sydney North Health Network talk would be complete without a mention of health pathways. So to reach the alcohol page, you get onto your health pathways site in your usual way using your password gateway and click on to mental health, go to addiction and drug misuse and then go on to alcohol. Or you can put alcohol into the search bar and it will come up. Without further delay, that's the alcohol page. That's what it looks like, and the information on withdrawal is further down the page. So without further delay, I'd like to introduce our speakers tonight. Dr. John Smart is a general practitioner who works in general practice in Hornsby and has dual interests in both primary care and addiction medicine. He was a Foundation Fellow of the Chapter of Addiction Medicine and has worked in major teaching hospitals and in the community in AOD, and has a long-standing interest in the treatment of viral hepatitis, particularly hepatitis C. He also enjoys mentoring other doctors in AOD. And our second speaker tonight is Dr. Chester Omana, who's an addiction psychiatrist at Royal North Shore Hospital. He was a previous director of the Prince of Wales Mental Health Rehab Unit and is particularly interested in comorbid addiction and psychiatric disorders. He also works in the private sector at Wesley Hospital, where he runs outpatient AOD clinics. And he also teaches both undergraduate medical students and postgrad doctors in AOD. So, without any further delay, I will hand over to John. Thanks, John.
Thank you, Nick. So we've had an acknowledgement of country. I'm going to present an acknowledgement of trauma, as this is an addiction evening. So I'll do this with a story. This is a family that's well known to me. So Alison was found naked and dead on Christmas Eve in the back streets of Darlinghurst in the year 2000. She was an 18-year-old polydrug user who supported her habit with sex work. She lived in Redfern. Alison's mother was born 55 years ago in a small town in Western New South Wales. Both of Alison's mother's parents had alcohol issues. Alison's mother had 7 sisters, all of whom had drug and alcohol issues, and 2 of whom were removed by welfare. Alison's mother herself avoided removal by hiding out in the bush. So in late childhood, Alison's mother was serially molested by a family member. Alison called this person out within her community and was blamed and cast out of her community. And she exiled herself to Redfern, where the cycle repeated itself. So this is 3 generations. It's a really terrible story. I'd like to acknowledge the effect of trauma on all of our communities, also multi-generational trauma, and also the effect of trauma on people providing care to people affected by trauma. So that's a little diversion from the main theme here tonight. So that's an acknowledgement of trauma, Alison's story. So tonight we've got 2 components to this. We've got the withdrawal or detox setting, and we've got a relapse prevention segment. So I've divided my withdrawal section into 4 different bits: general addiction concepts, patient selection, structure and protocols around running a detox or withdrawal within primary care, and some case discussions. Over to Nick, I think.
Yeah, so we've got a poll I should have mentioned before. We've got a couple of polls throughout the presentation. Pat, I'll just get you to put it up if you can. Just as it's coming up, I'll just read the question to you. The following conditions preclude home withdrawal. Oh, Pat, that's the second one. Sorry. Pat, can you swap the polls over? So, thanks, Pat. The following conditions preclude home withdrawal. 4 responses. First one, previous complicated withdrawal, history of seizures, decompensated cirrhosis, or daily intake of more than 12 standard drinks. I'll give you a clue. There's more than one response. So if you can click on what you think might be the correct answers, and I'll give everyone a few seconds to complete it. Okay. Let's have a look at your responses. Okay, so 97% said previous complicated withdrawal, precluded home withdrawal, 93% history of seizures, 72% decompensated cirrhosis, and 55% said more than 12 standard drinks. So the correct answer, next slide, please, is the first 3. So the first 3 are correct, and the last one is incorrect. So a daily intake of more than 12 standard drinks does not preclude you from having a home withdrawal. Thanks, John. Back over to you.
Okay, so we'll talk about some concepts. The world of addiction's not altogether straightforward or intuitive at times. So this is an important idea. Addiction is chronic and relapsing and based in the brain, and without treatment, things get worse over time. In relation to alcohol, alcohol is a particularly unpleasant drug, and the harms accelerate throughout the process. In addiction medicine, we try and operate in a value-free setting. That is, we don't do good and bad, we don't do right and wrong, we stay away from religious concepts as much as possible, and we just do medicine in the normal way that we do medicine. So that's a couple of concepts around addiction. So this is another idea here. It's surprising. You'd think that with all the excitement around a detoxification process, excitement and drama, there's going to be some really valuable and measurable outcomes. Well, there aren't. It doesn't really work, but it is very important. It's important because patients want to do it, and it's a process that gets them to the starting line to treatment. So rather than being a treatment in itself, it puts people in a place where they can enter treatment. So it's a prelude to treatment. Another very familiar set of concepts here, just the concepts of standard drinks. So in addiction medicine, like other medicine, we measure things. And in relation to alcohol, we're all familiar with the idea of a standard drink, 10 grams. That's what our liver metabolizes in an hour. A tinny is 15 grams. A bottle of wine, 7 or 8 standard drinks. A bottle of spirits, 24 standard drinks, roughly, depending on the spirits. A bottle of spirits is about the amount that the liver can metabolize in a day. If you're drinking more than that, your blood alcohol level is increasing and you're on your way to a bender. So that's the numbers. Now, relatively arbitrarily, there's no really good evidence about alcohol intake and severity of withdrawal, I start to get nervous around the 200 gram, 20 standard drink mark. And, you know, so that's my arbitrary but cut off, but it is where I try and stand.
John, when you say you get nervous, you're referring to the fact that you'd refer off to a tertiary.
Oh, look, I'm worried about what will happen during the withdrawal. And, you know, this is in the general practice setting, things happen at night in the person's home. So, you know, if I'm looking at the trajectory of the withdrawal, then I'm concerned about how this will progress. So, you know, I'm sitting there in the morning wondering what's going to be going on at 1 o'clock in the morning in the patient's home. So, you know, in my experience, you know, 150 grams should be okay. 200 grams, things can get sketchy. And you're more likely to end up with an attendance, an accident, emergency, or some complications.
Okay.
It's a fair amount of alcohol, 200 grams. You know, it's half a pound in the old money. It's a lot of a toxic substance. All right, another concept here. So, you know, doing a detox or withdrawal is more than just writing a Valium script and giving it to the patient. This is unfortunate. It still occurs. I've even seen this as the practice in major teaching hospitals at times. This is really quite derelict. It's not safe. It's not going to help the patient. I try and keep full bottles of Valium away from any of my addiction patients, including people who are undergoing alcohol withdrawal.
John, can I ask you there as well about Valium? If we're looking at someone, you know, who drinks a certain amount of alcohol, what are the clues to the fact that the person might need a medicated withdrawal? Meaning, how do we know if someone might need Valium? Is it to do with, you know, their length of time that they've been drinking, or the volume the amount that they drink? Is it, you know, previous attempts that have been unsuccessful, that have been unmedicated? How do we, as someone starting out, how do we sort of gauge that?
So, you know, usually patients are there because they think they're going to need something that's based on their prior experience on the whole. So you listen to the patient, they have some understanding of their condition. You know, the number of withdrawal attempts in addiction, you know, is enormous. So patients have a rough idea. If they've been drinking for some time, you know, if it's a daily drinking at 2 or 3 or 4 weeks, a substantial amount, it's quite likely, you know, if so if the person's there and is asking, I tend to presume that they know what they're doing and provide them with medications. So thiamine, so that's emphasized in this slide. It's really important. People that are drinking heavily are often deficient in thiamine and other dietary components. Now, thiamine's a vitamin that's very important in energy production in the brain. In the absence of sufficient thiamine, the brain can be damaged, and this occurs quite acutely in the withdrawal process. So there's another slide here about thiamine. So, you know, we're really emphasizing this. If you're detoxing people, you're taking a responsibility on yourself, and you need to do it right because harms can accrue. So we need to preload our patients with thiamine, 300 milligrams for at least 3 days. It's over the counter in the chemists. It's vitamin. It's not expensive. I keep some in my cupboard in my consulting room. So no thiamine, no detox. So this is what we're trying to avoid, which is Wernicke's encephalopathy. So as I've said, thiamine's involved in brain energy pathways. These pathways accelerate during the detoxification process. If there's insufficient thiamine, there can be insufficient energy for cells, and cell death can arise, and Wernicke's can create a persistent neurological deficit. And it occurs, it's quite real, it's not common, but you don't want to be involved with this. So what's Wernicke's? There's 3 signs. So eye ataxia, nystagmus, ophthalmoplegia, limb ataxia, and confusion. So we really don't want to be involved with this, and it's preventable. Okay, so that's a few concepts done. Now we're talking about which patients we're going to look after. Now, we're trying to do uncomplicated detoxes in, relatively well patients. So we've talked about the amount of alcohol. The general description of the patient is uncomplicated. That means somebody that doesn't have any unstable or serious medical conditions, or unstable or serious psychiatric conditions, no history of seizures, because that's a risk anyway, no previous complicated detoxifications, not pregnant, please, and no history of decompensated cirrhosis or current present decompensated cirrhosis, and also not a polydrug user. So that's a drug and alcohol term for people that are often using benzos, alcohol, opioids, or stimulants all simultaneously, and they're a more complicated group. So uncomplicated patients, we're looking for a mild to moderate sort of level of detox here. And so patient selection is important. Now the patients have got to have some other characteristics. They've got to be able to attend your rooms, and really that's in the morning, and it's daily during this process for up to 5 days. They need to be living somewhere that's safe. We might take this for granted, but in the addiction world, it's often not the case. So, I don't really want to be trying to withdraw people who are living in the park or in a cave or in crisis housing or with an abusive partner. The carer will be shepherding the person around. They can't drive. That person needs to be reliable too. We want to start early in the week, so we finish within the working week. And as I've said, we're not fit for driving or work or other major commitments. People often decide to make all their decisions at once, so they're going to withdraw, detox, and start a new job all simultaneously, and this is not a good idea. Okay, structure. So in medicine, we're used to working in a structured environment and in structured ways. Structure is important to us. In addiction, there are a lot of crises, and withdrawal or detox often occurs at a time of crisis. We still need to operate in our fixed ways, and it's important that we don't allow the patient's crisis to become our crisis. This is medically dangerous, and if you keep doing it, your practice staff are going to be protesting. So to make things safe and sustainable, we need to maintain a structure around this process, and it's a struggle. Okay, here's a regime. The patient attends the previous week, and we make an assessment. We start some thiamine if they haven't started already. We set a start date for the following week, ideally on a Monday morning, and the stop date for alcohol, which will be late the evening before. And we plan for the patient to be in attendance at the room when we're there, each morning for 4 or 5 days. And as part of this, during these attendances, we're giving the patients written instructions and dispensing medications. So what are we looking after here? So the alcohol withdrawal syndrome. So I think many of us will be familiar with this, but it can be quite florid. So alcohol is a sedating drug, and it, within the GABA system, when you remove alcohol, particularly a brain that's habituated to it, then the brain rebounds in an excitatory fashion. So the symptoms of alcohol withdrawal are all excitatory. So tachycardia, tremor, anxiety, perspiration, insomnia, hallucinations, and all the way down to more serious events. It's a pretty swift process. So here's a graphic. So things start, pretty rapidly. Alcohol's a short-acting drug, and the withdrawal will be well and truly going within the first 1 or 2 days, and will tend to settle within 4 or 5 days in most instances.
John, just a comment on that. I like the way you described it as being excitatory. Sometimes it's hard to remember specific the specific symptoms and signs of withdrawal. So, you think about being agitated, you think of sweating and being, super stimulated and having a fast heart rate. It makes it easier to remember for someone, just starting out. I just want to ask you, you've got the DTs up there, major withdrawal, and I think we all know the mortality of that's high. Is it something that you see commonly? I mean, should someone starting out be aware or not aware, but be anxious about perhaps precipitating that? And, how do we...
So look,
in
our resident days, this is the sort of thing that we would see in people in crisis and accident emergencies and arriving in ambulances, and this is what we're trying to avoid. So we're looking for people who are have mild to moderate degrees of going to experience mild to moderate withdrawals. If a person is living rough and drinking a lot, and has a long history and has got psychiatric morbidity, poor self-care, and presents late and in crisis, this is the sort of person that's going to have the bad outcomes. These are not the people we want to be dealing with in our practices. It's unwise and dangerous. So the answer is, I don't see major harms arising, but the whole process here is to avoid this. Okay, a little bit more on the protocol. So in the morning for up to 5 days, we review the patient, see how they're going. We ask about the thiamine intake and emphasize it every day. And that's a good amount of thiamine for a week, maybe longer, and then continue thiamine for a month. And emphasize if the person resumes drinking at some point, they should recommence thiamine. Maybe not at 300 a day, but they should be adding some thiamine to their diet. So I dispense diazepam daily from my surgery. That's just the way I work. It's simple and direct, and the dispensing is done, with careful and written instructions that are written in my very best doctor's handwriting in large capitals. You could do this through a pharmacy. I never give the script to a patient. It'll be faxed to a pharmacy, and it'll be a pharmacy nearby that I've got a relationship with. But I prefer to do it directly.
I guess the other thing, John, is do you sometimes perhaps give the script to their carer or their support person and ask them when they come in and, sort of tell them how many you want them to have on that day?
Generally not. I don't like to put carers, parents, and support people into situations where they may be involved in conflicts within their role. So,
yeah, that makes sense.
I like to, that I'm the difficult person. The carer is there to care and not to have an authoritative role or bargain with.
That's a good point.
Okay, so here's a generic diazepam regime. This has been around for a long time. It doesn't seem to change very much. It's diazepam 4 times a day, 5 or 10 milligrams, and some spare. So that's about 50 milligrams dispensed, once again, with written instructions. And this is done daily. So have a read of that. It's actually, could we pop back to that slide? So this is the, apart from patient selection and thiamine, this is my main take-home message here tonight. It's just a very simple regime, 40 or 50 or 60 milligrams, and taper it. So the diazepam should be gone within 5 days or a week. A detox is not the beginnings of a diazepam maintenance program.
What's the longest you'd perhaps continue diazepam for? 10 days or 12 days?
Yeah, maybe something like that. Or I've got in my opioid treatment program, I've got people who are on long-term dispensed diazepam, but in this setting, I try and avoid it. The combination of alcohol and diazepam is not a good combination, and there are people that alternate their alcohol and their diazepam, or don't alternate them and are using them all together. This is not a really great situation. do we want to answer that question, Nick, or questions just come up on the chat box? So I'll answer that. So this is from Alana. You know, would you give thiamine 300 milligrams for 3 days before detox for every home detox? And the answer from my point is absolutely. Absolutely. Chester, what would you say?
I would agree. There's very little downside, and there potentially some upside, and it can sometimes be hard to tell how good people's nutrition has been. They may not show it. It's hard to predict.
Okay, so here's an example of dispensing. So this is in an envelope, in my best handwriting. The instructions are explicit: timing, dose, total amount of medication. I do this because people are often not at their best during a detox, so the instructions need to be clear. Also, it's not legal to carry around undispensed, unformally dispensed S4s. So if a patient comes in contact with the police and their pockets are emptied, then this prescription or just will keep the patient out of trouble. So that's an example. This is done daily. The date, my identity, total amount of drugs, and the regime. So Lynette, no hypnotherapy during the detox process, really. Perhaps if the patient wants it later. Okay, a little bit more about diazepam. So this is a benzo that has a very long half-life, really weeks. And we like it because it smooths things out. However, the long half-life can have a problem if the person's liver isn't working well, and the diazepam can accumulate. In that setting, we would want to use a shorter acting benzodiazepine, such as oxazepam or others. Really, in this setting, you know, this is not for primary care.
John, can I just ask you about decompensated cirrhosis? What are you referring to? You're talking about taking some bloods on every patient before you offer a medical withdrawal, or are you talking about a previous history of liver dysfunction? Are you talking about albumin levels? What are you?
So just the clinical history. If the patient's had an episode and they've been told that they've had decompensated cirrhosis, or you know, if they've had ascites or jaundice or peripheral edema or variceal bleeding, or an encephalopathy. I don't tend to do bloods before doing a home detox. Really, the process here is moving too quickly for most people, and people want to withdraw now, and I try and slow that down enough to make it safe, but not to throw additional barriers in the way of the process. So yeah, I can talk about the biochemistry in cirrhosis, but it's probably not terribly relevant. Okay. All right. So aftercare. So you know, I've said that detox is not really a treatment, but it's a prelude to treatment. So aftercare is where the value really is. So it takes time for people to change themselves in their lives, and this occurs during, you know, a long period of abstinence, and this is a process to carry out during aftercare. So, you know, in the lingo, anybody can detox, but staying dry long term is where the good things happen. Okay, so do we want to take some questions, Nick, or what do you think? How are we for time?
Anyone with any questions at the moment, or should we go on to the case histories?
I've got another a comment here. I recently sent somebody away on Friday who presented on on a Friday evening, not preloaded on Biedermann as I was.
That was me.
Yeah, I think that's the right thing to do. It's difficult, but the patient will do what they want to do over the weekend, but you've got to, you don't want to be involved in this process because it's potentially dangerous. And, you could ask the person to reduce their drinking a little and come back and see you on Monday after they've had some thiamine.
Yep, that's actually what happened. So, yeah.
All right. Okay, there's a couple of cases here now. I see we've got 59 participants. This is something of a record for a drug and alcohol teaching session on the north side. So thank you folks for coming along. I'm always very grateful when people want to come and listen to addiction medicine. It always surprises me. Okay, this is Jane. This is a good story. So Jane's a 47-year-old mathematics teacher. Lives in a pretty conventional setting on the upper North Shore, or Hornsby area. She's got a few minor comorbidities, manages her anxiety with some Lexapro. Home life isn't very flash. Husband's got a chronic pain syndrome, which is not very usefully treated with opioids. Her son's got, either high functioning autism or low functioning Asperger's. She's an ongoing problem. She describes her home life as poor, and she doesn't enjoy it very much. She's got personal plans to do some further study and do some data science. And she's drinking a fair bit. She's drinking 2 bottles of champagne a day and has been for a long time. And we've detoxed a number of times in the past, and the outcome's been pretty good, but we're relapsing. So here we are, and I'll have the next. Oh, no, there was a question. I'll just deal with it, the chat box question. Look, there isn't for Jerry, how many daily drinks could a person be having to safely stop drinking on their own without medically assisted detox? There isn't a firm answer to that. If the person's there to see you, then I'd offer some assistance. You might just reduce the amount of diazepam you're providing. Really, the value here is that by going through the detox process with the patient, you set up a relationship, and you can use that relationship to encourage people into aftercare. So, holding people's hands through a detox is very valuable in terms of the doctor-patient relationship. It provides the doctor with currency that they can use later. All right, so back to Jane. So she's turned up midweek, and she's feeling pretty sad and sorry, and she had 3 bottles of champagne yesterday, which wouldn't make me happy, and no thiamine, and she wants to start a detox now because she wants to get on with her life. So actually not. So next slide, please. So we've asked to start in the next week after we've had a good amount of thiamine for a good amount of time. So here we are on Monday, no alcohol overnight, and she looks pretty good. Her heart rate's a pretty simple indicator of what's going on. And I've given her the regular amount of diazepam and talked her through the process. Day 2, again in the morning, she's using a thiamine. She didn't use all the diazepam. She's not tachycardic, and she's not tremulous, and she looks pretty good. So we started to talk about aftercare, talked about some support groups. I'm going to put in a plug here for my local drug, alcohol and gambling service at Hornsby Hospital, who've been looking after my patients for decades now and who've been tremendously helpful and for whom I'm very grateful. Also talked to about a dry days phone app. So we'd like to count the days. 100's a good number to start with. And there we go, that's day 2. So we'll just flip the next slide. Day 3, going pretty well, and she's not drinking, and she's actually working on her aftercare, so she's into the intake process. Day 4, she's got a few symptoms, blood pressure's up a little bit, still needing a diazepam. She started the intake process, which has now been centralized, a little bit less Valium. And, you know, we've been talking about peer stuff. So she's chosen a smart recovery group, which is perhaps a little bit more contemporary than AA. So that's day 4. I'll carry on. So further down the track, day 10, no more Valium. We're dry. She's not craving. She's getting some counselling. She's involved in a peer support group, and there's no real need for relapse prevention medications at that time. So that's Jane. That's a good story. So Jane's in again. 100 days dry on a phone app. That's a good number. That's where we're aiming for. And we've been doing our reviews weekly for the first month, second weekly for the second month, and then monthly. This is arbitrary, just a simple way to work. I do offer a limited warranty for this process, and that is that if people see their doctor regularly, they're probably going to do well. If they aren't seeing their doctor, then the warranty is void. So that's got to do with continuity of care, and it is an important indicator in how well patients are going. All right, so that's Jane. Now, this second case was a little bit more problematic, and I've put it up as an example of how things can go mildly wrong. So Peter's 59, very well known to me, very much liked within the practice, quite an affable and sociable fellow. He's had some life traumas that we've been through. He was a high functioning international executive, out of the country a lot, flying a lot. He's very energetic. I've never assessed him for ADHD, but his brother in the UK had ADHD and criminality, which, you know, raises the possibility, at least in the family, of some personality disorder issues. Peter's had a really long affair with alcohol, and he's not damaged, but, you know, it's been a problem. So next slide. So anxiety in the background, sometimes some depression. He had a monster binge during a cricket test some years ago and put himself into heart failure and atrial fibrillation, which improved. He's back in sinus rhythm and hasn't recurred since. Background of hypertension, and all his bones and joints are aching because he's been a pretty busy sportsman. So that's Peter. So this is a COVID story. He turned up in, you know, peak COVID, winter, in isolation, and he'd been drinking pretty heavily. He'd been drinking a bottle of vodka daily at least for 2 weeks. This is a lot of alcohol. He had taken his thiamine, which he'd learnt during previous detoxes, and he'd already began to detox at home. So he thought he'd come and see the doctor into the process. And he presented, you know, with a good going alcohol withdrawal syndrome early in the piece with a high alcohol intake. So I wasn't tremendously comfortable here. However, Peter was attached to me in the practice, and, you know, I was on very cordial terms with him. His partner was with him, and she's now a dry ex-drinker. And so I was quite uncertain what I should do here. However, Peter was adamant that he wanted to detox at home with his capable partner's support. So off we went, even though the timing was all wrong. So gave him the usual diazepam and a bit extra, talked him through the process along with the risks at some length, and, you know, explicitly advised him to attend accident emergency overnight. So the concern here is the trajectory. You know, if people are in one position when they see you, where are they going to be 12 hours later in the middle of the night? That's the thinking that's going on. So the next day I wasn't in the surgery, and part of the problem, and if anything, he was worse than he was on the first day. He had been to A&E overnight and given more diazepam, and he and his partner had had enough, and they were wanting to find a private detox and get in. And so the partner was on the phone, actively working towards that. So next slide, please. So he ended up with a 3-week admission to Sydney Private, which is quite a well-known psychiatric hospital in the eastern suburbs, alcoholic hepatitis, possibly some pancreatitis, discharged on a lot of psychoactive medications and relapse prevention medications. So I saw him post-discharge, which will be the next slide, I think. Peter, was an experienced detoxification patient, and he'd decided to discontinue all his relapse medications. His psychiatric medication of preference was mirtazapine, so he's recommenced that. He stayed with the relapse prevention groups from the clinic, so he's doing those by Zoom, and he's also taken up with his old AA network. All of this is good, and he was well, and not to, he didn't want to repeat this process, but he hadn't suffered any great harms. So, around Christmas, he had a minor relapse, which he pulled up himself quite quickly, and now he's going well. So, that's Peter. I'm a bit ambivalent about this. Anyway, I got caught with him, and that's how it played out.
John, can I ask, for people who are new to home withdrawal, do you see value in doing the alcohol withdrawal scale in terms of guiding your dose of Valium, or knowing when you might need to send someone to hospital? Or I know you don't typically use it, but can you see a place for it?
So the uses for this are in communication. So if there's a situation where there are multiple people looking after an individual, then the score communicates the situation. So that's useful. In my personal history here, what I've found with scoring systems generally is they just tell me the questions to ask. So you might learn a scoring system, use it for a while, and then you don't need it anymore because you know what's in it. So you just ask the question. So they're quite a useful educational tool for the practitioner. If you've got time, use them. Otherwise, look at the patient, listen to them, touch their skin, take their heart rate, see whether they're shaking, look at their eyes, take their blood pressure, ask them how they feel. So that's basic clinical medicine. But if you want to use an alcohol withdrawal score, and we've got one later in the night, so that's fine. And if you're in an institutional setting, it'd be pretty much mandatory. Yeah. Great,
thanks. Okay.
So yeah, we'll hand over to Chester now. So another punt here. This is about aftercare. Anybody can detox. It's getting your aftercare right and keeping it going is what's going to help your patients in the longer term.
I don't know if you guys have seen the question that's up on the chat box at the moment. Treating the symptoms. So when do you consider the etiology of the usage?
Well, I think Chester and I will both have a go at this. So, addiction's the surface layer of the underlying problem. So when a person's seeing an addiction doctor, they've usually got two problems. They've got their addiction and they've got the underlying problem. And so, I'm always looking to see what the underlying problem is and to treat it as it plays out. But it's not the primary concern initially. So I'll answer the next question from Victor here. Yeah, look, you can continue to do home detoxes on the same patient, but at an interval, really you want to look at what's going on in the relapse prevention front. So why are they continuing to relapse, and how do you change your relapse prevention modalities to prevent the relapses? Alcohol addiction is a severe disease. People end up with brain damage eventually. The brain is the most important tool we have for sorting out our problems. So it's important to try and get this patient sorted before they really get significant damage from their addiction.
No, I would agree with that. That I guess you have to deal with both the addiction and the underlying etiology. Once the addiction embeds itself, it becomes its own beast, and it gets more and more severe with time. But then there's obviously a lot of contributing factors, from trauma to depression, and often social isolation. And it's really, you have to sort of tackle both sides in an integrative way in order to make progress often. Okay, so I'll just go through my presentation. Thanks a lot, John, for your presentation. So I just wanted to first of all overview the sort of elements of treatment, and John's gone through, kind of really a very good description of how he engages the patient really over a long period of time. And it sounds like a lot of the patients are well known to John over a period of time. There's probably a process of gradually moving through the various stages of change towards, kind of a position where they, there's a motivation for action. And there's ways of learning how to do that, most notably with sort of brief interventions in a motivational interviewing framework can be very effective and can have, quite an effect months and potentially, years after the initial intervention. Quite when the person crosses the line is a little bit hard to predict. But as John said, also as part of the engagement, you're also trying to kind of sort of slow things down and pause to plan the withdrawal in an organized way and not reacting to the latest crisis, and more importantly also to plan the elements that would be required to prevent relapse. And John showed how kind of after his patient, seeing his patient through detox, he kind of builds into the aftercare a kind of system of almost checking in and checking out with him over, a gradually decreasing frequency, which would be a very helpful way of providing a structure in order to both measure time and be able to kind of reflect on things and also sort of celebrate some of the successes to maintain motivation. Within the relapse prevention, medications is a very small portion of it. I've been asked to focus on this primarily, but I wanted to ensure that people are aware that it really is a small part of it. Individually, people will do all sorts of environmental and sort of relationship adjustments in order to reduce the risk of their relapse, from making sure that their sleep is able to be kind of improved, their diet improves, that they've got more people around them, there's more contact with friends and family, maybe changing where people go socially, and reducing access to alcohol at home. And people often, spontaneously do that, but often through structured counseling or in the kind of engagement phase, a GP can also help with this to try and look at the various elements that might create an environment that is less likely to contribute to a relapse down the track. Peer support is often a very important component. That could be a smart recovery groups or AA. And medications are a kind of reasonable option for some people, and do increase the likelihood of abstinence or reduced harm in several cases. And then for quite a few patients, residential rehabilitation will be necessary as well. So there's 3 medications, as most people be aware, that are TGA approved and show superior effectiveness compared to placebo, but they've all been shown to be superiorly effective when combined with psychosocial interventions. And those are disulfiram, naltrexone, and acamprosate. And all agents are recommended for use of over 6 months. So now we just got a quick poll to sort of look at people's basic understanding of these medications. Do you want to take it over, Nick?
Yep, sure. So the poll will appear on your screen in a minute. It's 3 questions, and the responses are the potential answers are the same for all 3 questions. Acamprosate, naltrexone, or disulfiram. Just waiting for the poll to pop up. There we go. Okay. So the first question is, medications used for relapse prevention that decreased alcohol craving include? Second question, which medication reduces alcohol reward? And third question, which medication can reduce anxiety? If they don't all appear on your screen at the one time, just scroll down and there's one answer for each question. Okay. So for the first question, medication used to decrease alcohol craving, 63% said Campral, which is the correct answer. For the second question, which medication choice reduces alcohol reward? 44% said naltrexone, which is the correct answer. And for the third question, which medication can reduce anxiety? And once again, it's Campral, so 44% answered that one correctly. Thanks, Pat.
Okay, thank you. So just looking at the questions on the side, there's been a couple of questions here on antidepressants. Carrie's asked, mirtazapine better than other antidepressants in patients with comorbid alcohol dependence and depression, seen better results. And someone else mentioned Cymbalta. Similar to the question that was asked before, I guess, in terms of sort of treating the etiology, depression, a very large proportion of people who are drinking heavily will be depressed. A significant proportion of those, the depression will resolve when they stop drinking. However, quite a few of them will have kind of comorbid depression. The kind of prolonged activation of the reward pathway does tend to lead to a reduction in serotonin levels. So quite often antidepressants are quite helpful. Mirtazapine in particular is helpful because sleep is specifically really impacted by alcohol use. Not something I'm talking about so much in this presentation, but it can be very helpful for that purpose. But any of the serotonergic antidepressants would be reasonable options if you think there's a comorbid depression, and it's often best to treat both simultaneously. But without dealing with the alcohol, it's pushing sort of up a very steep hill, and it can be very hard to make progress.
So just to clarify that, so you're using your antidepressants as antidepressants,
yes,
not as relapse prevention drugs.
Absolutely, it's treating both conditions, the alcohol and the depression, simultaneously. Okay, so So next, sorry, this is just the answers. That acamprosate is the one that mostly decreases alcohol craving in terms of reducing reward. Naltrexone and acamprosate has an anxiolytic feature about it as well. So I just thought I'd just remind very quickly about some of the neuroanatomy. You know, the main thing to look at is essentially the reward circuit. And it looks all very complicated here, but it's just focusing here on the VTA is where the dopamine neurons originate, and they shoot off in a range of different directions to the amygdala, which is where emotion is encoded, to the nucleus accumbens, which is where motivation and movement are kind of begin to be planned and set in motion. Prefrontal cortex, where attention is gathered, and the hippocampus, where memory and context are kind of sort of built together. And for alcohol does a number of different things. It releases dopamine, so it will lead to firing of all these different pathways. It also releases opiates in association with the firing of this dopamine, so you get a kind of reward sensation. This system tends to be dampened down by the GABA system, that is the brain's off switch and generally kind of sedative neurotransmitter, and alcohol potentiates this particular route. And the other thing that it does is that it dampens down the glutamate response, which is the kind of on switch of the brain, the main excitatory neurotransmitter. And so all of these things are quite relevant when it comes to how alcohol causes the harm that it does, and how the medications, you know, kind of have their effect. The positive reinforcement of alcohol comes from the dopamine release, which gives you a sense of purpose and pleasure, and the opiate release that gives a kind of reinforcing quality about it. But probably more important is the kind of negative reinforcing effect of alcohol, which is that over time, with the recurrent dampening down of the GABA system, the brain adapts to it by upregulating that system. And so when alcohol isn't present, these will be sort of shooting off and leading you to a state of agitation, which is what we see as withdrawal. And that's a really unpleasant state that sort of shoots off, let's get something, remembering all the kind of unpleasant things that have happened, that emotional tagging, and trying to recall the context of what you can do in order to get yourself out of that situation. And then alcohol comes back into that situation and suddenly puts in a warm, soothing blanket over all of this discomfort and takes it all away. And that is the negative reinforcing effect of alcohol, that it takes away the pain that was created in the first place by alcohol. And that removal of the pain is encoded very strongly in the amygdala. Is encoded very strongly in the amygdala, and the context in which that happened in the hippocampus. And then when you're in a situation where any of that context comes up again, it could be a person or an emotion, then suddenly the cravings come back and fire off the whole system again. And so that's shows you sort of how alcohol kind of hijacks this whole motivational system and this whole sort of seeking circuit. This is just a a summary really of what I've talked about, and you can look at it later. So now looking at the medications, naltrexone is the first one I was going to talk about, and that's an opioid antagonist. And so essentially blocks the effect of the endorphins that are released when some people drink. That kind of reduces the buzz that some people get from alcohol. We usually would prescribe 50 milligrams a day. Often would start at 25 milligrams for a couple days for tolerability, because you can get headaches and nausea with it, and some sedation. And it tends to be more effective for people that have had a history of binge drinking, particularly in the initial phases of drinking, and where they used to get a kind of very reinforcing euphoric effect from alcohol. Often with people that haven't had decades and decades of very, very heavy drinking. You need to be cautious with people that have got quite deranged liver function, and generally would only be prescribing this to people with LFTs of no more than sort of 3 times the normal range, and obviously not for people taking opiates. It is safe for people who intend to continue drinking but want to drink less, and in that way it's a little bit different to some of the other medications.
Chester, could I ask a quick
Sure.
question here on naltrexone? What about people who use alcohol to help them fall asleep? Does naltrexone have benefits there?
Yeah, look, that's probably that's a different issue there, and one that kind of needs to be tackled, and it's very, very common. So they, in a short answer, no, probably not. Because it's not a kind of positive sort of euphoric feeling that you're getting from it. But the etiology there is that alcohol, by its nature, will come out of your system when you sleep. And therefore, most people are in mild withdrawal when they're asleep, and they get an adrenaline surge, which gives them very, very low quality sleep. And then they will often overcompensate by sleeping in later and disrupt their circadian rhythm completely. They become very, very fixated on sleep and a great anticipator anxiety about what's going to happen if they don't sleep. And remembering that the negative emotion that's encoded so powerfully in the amygdala is the trigger. And so they're essentially re-triggering themselves every single night to drink in order to prevent the pain of not sleeping. And that's something that probably needs to be tackled separately. So this is showing a little bit about the kind of relapse curves for placebo and naltrexone. There is kind of in the RCTs, there's a significant effect of naltrexone across the population using it, but it's not dramatic. It's not going to, on its own, sort of rewrite the history books, but there is definitely an effect there. Next medication I was just going to talk about was Camprol, acamprosate, and this works as an analog of taurine, which is closely related to GABA, and it mimics the effect of GABA and also has some blockade function on glutamate. And so if you were to go back to the sort of neuroanatomy, could have a sense of why it might work as it does. In terms of the dosage, you usually would prescribe 2 tablets 3 times a day. Often might start at half this dose for a couple of days, because you can get some gastrointestinal side effects and sedation. With people who are under 60 kilos, that sometimes you might give them 666 milligrams twice a day, so 2 tablets twice a day. In renal impairment, you'd lower the dose to 1 tablet TDS, and if it's severe renal impairment, you wouldn't be using this medication. You can use it in mild to moderate hepatic impairment, but in severe hepatic impairment, you probably wouldn't use it. And the trials for Camprol have shown mixed results, and there are quite big differences between different trials, but on the meta-analyses, there seems to be a fairly robust effect. The effect tends to be, whereas naltrexone has an effect more on reduction of heavy drinking days and amount of alcohol consumed, Camprol seems to have more of an effect on prolonged abstinence. And so they seem to have a slightly different mechanism there. And there is some evidence that combining the two can be beneficial, and it's worth thinking about that. The final medication that's approved is antabuse, and this works by a very different mechanism. It essentially is an irreversible inhibitor of aldehyde dehydrogenase. So you essentially build up an intermediate product called acetaldehyde that's mildly toxic, and makes you, it's vasodilate, so you get a really bad headache and a flushing, and you get nausea. And if you drink and get significant acetaldehyde, you can get very, very sick. And that's the kind of antabuse reaction that we warn people about. If you get sufficiently sick, you obviously can become dehydrated. It can become quite dangerous. So you need to counsel people about if they do get to this situation, you need to go to emergency, and it's reversible with fluids, and usually no big harm. But if someone's got serious cardiac issues, you wouldn't be going down this route. You take 1 to 2 tablets a day. If people aren't getting a reaction, if they test it on 1 tablet, you go up to 2 tablets. Would start on half a tablet for a couple days to improve tolerability. Now, this medication is something that obviously if someone's taking opiates, you wouldn't use. It's only compatible with abstinence. And it's really suited to people who are kind of more motivated. And if you look at the studies, there's very good evidence for it when it's supervised. But when it's not supervised, there isn't very good evidence. So you would want to team up with a pharmacist to dispense it daily, or perhaps a significant other or a colleague at work, if there's a trusted relationship or a trusted friend. But just as John had said, you want to be very cautious about, making this into a situation where one person is checking up on the other person. So the frame with which this is done is very important. You need to, when it is supervised, it is probably the most effective pharmacotherapy, and probably more effective than in meta-analyses, it's been shown to be more effective than naltrexone, Camprol, or topiramate. You do need to check LFTs at 4 to 6 weeks, because occasionally you can get liver inflammation from this. Obviously, you need to avoid all alcohol, and that includes hidden alcohols like perfumes, salad dressings, things like that. The reality is that probably most of those are okay. Some people can get really quite obsessional and terrified about it, and then avoid it altogether. But it's worth having that conversation. And if people do want to restart drinking, they should stop for 7 to 10 days. And the reason for this is that it's an irreversible inhibitor of the enzyme, and it takes that long to synthesize new enzyme. The problems with it is that it's not subsidized by PBS, unlike the others. So it's costs $70 a month or thereabouts. And obviously you need to be relatively healthy from a cardiovascular point of view and need to educate quite carefully. So just sort of summarizing these, the differences. So from a cravings, acamprosate can reduce the cravings and anxiety through that GABAergic effect. Naltrexone primarily that reward effect, and disulfiram is the aversive reaction. Naltrexone and disulfiram have the benefits of being once daily dosing, and both of them can have that property of being able to prevent slips becoming relapses. And I probably should have mentioned before in the kind of the overall framework of thinking about this, that how you think about slips is very important. And as John had said, that most people will have been through many detoxes and many slips. And a frame where you think about the slip as actually you know, an opportunity to re-engage in treatment and to increase your motivation is quite important. Acamprosate can be helpful for insomnia, but being 3 times a day dosing, often adherence is a problem. You want to avoid in cirrhosis, you want to avoid Camprol, and probably you want to avoid naltrexone and disulfiram for sure, and probably Camprol in severe cirrhosis and renal failure. You probably need to avoid all of them. And heart disease, diabetes, Camprol and naltrexone would be okay, but antabuse wouldn't. Okay, so there's a whole range of other medications that have got evidence in alcohol dependence. And I'll just talk about a couple on this list, baclofen and topiramate. Just quickly to mention, Vivitrol is a depot version of naltrexone, which is available in the United States and has some evidence there. Nalmefene is another opiate antagonist, which is popular in Europe, and reasonable evidence there. Varenicline, which is a Champix, can be useful for relapse prevention for male smokers. And at the bottom there, serotonin reuptake inhibitors to treating comorbid depression. And often it's quite difficult to deal with one without the other. Okay, so looking at topiramate, topiramate is become quite popular recently. You know, whether it'll be as effective as people are hoping at the moment is unclear. Its mechanism is it's a GABA-A agonist and also a glutamate antagonist. So thinking back to, you know, some of the mechanisms by which it works is sort of similar to the way Camprol might work, but some evidence it might be more effective. It's got significant side effects, which are mostly neurological. In particular, people complain about kind of problems with memory, concentration, feeling foggy, sedated, and very slow titration can help to reduce these side effects. The slow titration means you probably need someone who's fairly organized, and you know, people might get a bit impatient with it. You'd begin at 25 milligrams a night, titrate up by every 4 days up to 150 to 200 milligrams. And the RCTs, there's been 3 of them with 600 odd patients, and they've shown reduced drinking days, drinks per day, and heavy drinking days. So all the way across all the treatment outcomes. It's used for a range of impulse control disorders with quite good effects. So binge eating disorder, it's used for OCD, and it's has some efficacy in borderline personality disorder, and you know, potentially in bipolar disorder. So with people that have got kind of some comorbidities there, it certainly is a reasonable second or third line agent to consider.
Just on topiramate, it seems to be very popular at the moment. When I see patients who've come back after being in a tertiary institution or, you know, seen a addiction psychiatrist, they're often on topiramate. Is there a reason why it's prescribed so much at the moment?
I think it's that there's been a few randomized trials in the last few years that have shown, you know, significant evidence, and it's outperforming naltrexone and Camprol in some of those. but it's early days. There's small number of trials, and certainly if you were, the evidence for, you know, in other conditions is greater, and it might be that in some of those patients they've got comorbid impulse control conditions, but you know, sort of anecdotally, it is very effective in some people, but hard to tolerate for some people as well. I'd say another thing that, you know, in general, in alcohol and addictions, there tend to be you know, phases where people get very excited about certain medications. A little while ago it was baclofen, now it's topiramate, and great claims are made at times, often by, you know, by patients from the ground up, and it's hard not to get carried away with that, and you know, kind of wait for the evidence to come through. We'll see how things emerge. So the next medication I wanted to talk about briefly was baclofen, which is a GABA B receptor agonist. And between GABA A and GABA B tends to be more around anxiety, particularly around the sort of the limbic region. And so it's quite an anxiolytic drug. This it also kind of inhibits dopamine release, and it kind of, I guess the excitement with baclofen really kicked off in France about somewhere around the mid 2000s. A French cardiologist, Dr. Amundsen, wrote this book called The End of My Addiction, in which he was on high dose baclofen of up to 270 milligrams and attributed his complete abstinence to it. And it's widely used there and has actually been accredited for use there. The RCTs have had mixed results, and there are some risks in overdose. There's risk of dependence, but there's no doubt that for some people it is very effective as well. One other thing just to talk about, you may have heard about, is called the Sinclair method, and this is just a slightly different way of prescribing naltrexone. And here the opiate antagonist is given 1 to 2 hours before drinking alcohol that day. And if you don't drink alcohol, you don't take medication. But the critical thing here is that without fail, you have to do this. So the idea is you're extinguishing the addiction by separating the pairing of the reward, the positive reinforcement, from the alcohol. And at other times, you'll get the positive reinforcement through other things like sex or food or relationships, friendships, and so on, and get this sort of, or exercise, and you'll get the dopamine, the endorphin hit and the dopamine hit without the alcohol. And you remove alcohol as the prime cause of reward. In theory, it takes 3 months to 2 years, and there have been claims of very, very high success rates. But I have to say, when I look through through papers, it's actually very hard to find the evidence base for this. But it does make a certain sense behaviorally and pharmacokinetically. And I guess when you're beginning the process of engaging people, and people are thinking they might want to reduce drinking and so on, this is a medication that people might sort of kind of accept, and then kind of as they dance in and out, they may decide they need to take further steps. There is a particular documentary that sort of really popularized this, called One Little Pill, which you can look at, but just worth knowing about because people may talk to you about this. So just wanted to sort of make a plug for a randomized controlled trial that's being done out of RPA with Royal North Shore, that's comparing topiramate to naltrexone. It's running at the moment, and any GP can refer. There's a phone number there that you can call the researcher directly to refer someone, and people get sort of 12 weeks of medical appointments, medications. They have kind of baseline blood sampling for genotyping, and also kind of counseling for around adherence. and referral to counseling as well. And the inclusion criteria is really pretty much anybody with an alcohol dependence between 18 and 70 who drinks over 25 or 30 standard drinks. So it might interest some people if they don't mind doing all the additional stuff. And in research trials, often the additional stuff actually does serve to create a certain structure around the whole process that can actually help the motivation and sort of breaking down the problem into small chunks. Okay, so
Chester, there's a couple of questions.
Oh, sure.
I'll run through them now. So Sally's asked, she's got a patient who's a policeman in his 20s. He suffers from anxiety and has been binge drinking on his days off. He's finding it hard to stop. He's on Prestige 200 milligrams. Which drug is appropriate for his alcohol problem given his occupation?
Yeah, I guess it would depend on how much he's binge drinking and the harm and so on. You do all of that that side of things, but I think naltrexone would seem to be the most likely option there. And kind of, I guess he's in his 20s, so hopefully he hasn't yet accrued significant hepatic damage or cognitive damage. The naltrexone would be where I'd start.
John, have you got any comments on that? Just unmute yourself, John.
Yeah, I'd go the same way. The police system is very hard on any policeman that has an appearance of impairment, so I'd be nervous about offering anything that might be sedating in any way or affect his judgment. So that so no baclofen and a little bit less keen on acamprosate.
Yeah. Okay. And another question that's come through the chat box: how do you decide which patient requires relapse prevention in terms of medication, not in terms of other services, but in terms of relapse prevention medication?
Look, it's actually often a patient decision, and as people are kind of going towards the detox, like the engagement phase and the detox phase, part of thinking about the most important part of it, which is the relapse prevention, is what are we going to do that's different from last time? Because the process of detox itself is quite toxic to the brain. It's less so if you manage it properly with adequate amounts of Valium and inhibit that glutamatergic state. But even so, it's not a helpful thing to do. And so you don't want to do it an infinite number of times. So I'd be just putting it to the person who's done it. How many times have they detoxed before? What's worked, what hasn't? Get them thinking about it. And, often it's, kind of when you start getting to the really pointy end where the consequences are really, really high, I kind of sort of say, you've got to throw everything you can at this, and you don't really know what it is that's going to ultimately make things stick, but you want to do something different each time. And I take a fairly pragmatic and sort of relaxed approach, and don't really mind what it is that works. Keep on throwing things until something sticks.
Thanks.
Any other questions? Or there?
No, I don't think. I think we've answered all of them. You've talked about baclofen. So yeah.
Okay, so I just wanted to sort of reiterate that we now have a centralized intake number for Northern Sydney LHD. It says 1300 889 788. So you don't need to think beyond that. Either the GP or the patient can call. If the GP calls, they just quickly take the patient's details and, kind of very overview. Is the person looking for counseling, or is it about alcohol? And then the intake person will then take it from there. They'll call the patient, discuss the relevant services, which might be drug and alcohol counseling, a specialist, addiction specialist appointment, or arranging admission to the inpatient unit, and it's taken from there. So I encourage you to use that. So next, I'll hand over to Nick, who will talk about other services.
Thanks, Chester. That was great. Just a few quick pages with some other referral options and resources for GPs. That's the number for the centralised intake that was on the last slide. Odyssey House provides services for adults, including counselling and family support and entry into the Merit program. They have 2 offices on the North Shore, one's in Chatswood and one's in Kirribilli. SDEC, which is Sydney Drug Education and Counselling Services for young people aged 12 to 25 and their families. They have fantastic support services for parents, and they run group education things for parents of young people. They're in Manly and St Leonard's. Kadesh is an NGO which provides low-cost inpatient and outpatient rehab services. Their inpatient unit's based at Mona Vale Hospital, and it's lovely. It's just been built. It's in a really fantastic location. They have 10 beds. It really is low cost, and they're not full to the brim yet because they've just opened a couple of months ago. So I'd highly recommend that. Then the 2 private hospitals that are available on the north side are the Northside Group, which provides private inpatient and outpatient rehab services, and South Pacific Private in Curl. They have inpatient services, private inpatient services, and they have outpatient services that are available to their patients who are inpatients beforehand. And there's the number for AA. Next slide, please. Thanks. DASAS, for those of you who don't know DASAS, they're a service that provides one-on-one specific information for GPs. It's staffed by addiction specialists, and it's a voluntary service. It's a 24/7 service. You ring the number, and someone calls you back, and I've used them twice in the last couple of years, and they've called me back in 10 minutes, and it's been invaluable help on how to manage someone who is in a crisis. So I highly recommend that. The AOD clinical attachments are still available with the Northern Sydney LHD. Contact Pat Simmons from the Sydney North Health Network to arrange that. They're really fantastic at the moment. They're running at Brookvale and at North Shore Hospital, and the attachments are remunerated. So, if you take time off work to do one of those, you'll actually be paid for attending. Health Pathways links there, and the Northern Sydney Health District Drug and Alcohol Service also have a brochure with their specific services listed if you want to click on that, including perinatal services and Merit program and so on. And last slide, please. 2 resources which may or may not be useful. I find them useful. One's the alcohol withdrawal scale, which is available on the Health Pathways page. And the second is severity of alcohol dependence questionnaire, which may help you manage your patient. That might be useful. All right, well, that concludes tonight's webinar. I'd like to thank our 2 fantastic speakers, John Smart and Chester Omana, and I'd also like to thank Robbie Robinson and Pat Simmons from the Sydney North Health Network, who have been fantastic in organising this.